Chapter 31, Acute Leukemias. So we'll go over the different classifications of the type of acute leukemias. There's acute lymphoblastic and acute myeloid leukemias, and then there's one where we're not quite sure where it comes from. That's called ambiguous lineage. And then cytochemical staining. So leukemia is classified into two groups. In this particular chapter, we're just going to cover the acute group. Chronic will be talked about in later chapters. So a lot of the classification will depend on how aggressive it is. In other words, how fast it grows, how detrimental to the patient it may be, and to the type of cell that's involved. And then once we get that classification, we then look at what the cells look like, the morphology of it, and then some other kinds of testing that can be done, which we'll talk about cytochemical staining. In other words, stains that we use to bring out certain special aspects of each cell, and then immunological staining, which is the clusters of differentiation, the CD markers. So acute leukemia is of a short duration. In other words, quick. I mean, I've seen it happen in as fast as 5 days. Person was totally normal. 5 days later, their white count went from totally normal at 5,000 up to 83,000 and 80% blast in less than 5 days. So it's very quick. So they call it a sudden onset. In other words, it happened very fast. So what happens is, to be an acute leukemia, we're starting to see immature cells in the bone marrow and the peripheral blood. It all depends on what type of leukemia, if it's lymphoid or myeloid, when we start looking at it. But the classification according to WHO and FAB is there has to be greater than 20% blast in the bone marrow. So it's very crucial that a bone marrow is done to determine the number of blasts that we see in the bone marrow, because it should be no more than 1 or 2%. So now we're talking about greater than 20%. And usually the problem that we see with people with acute leukemia is the blasts stop there. They really don't mature at all. So now they're non-functional, but they grow so fast. So they stop at this immaturity. Now it can be the blasts or the pro-myelocytes or pro-lymphocytes or whatever, but they don't mature like they should. Right? So one of the things that we look for is normally there's a feedback mechanism that controls the cells to grow. So without the proper regulation of feedback, the cells aren't doing what they're supposed to do. They're not controlled correctly. So what that will do is it will cause hematopoiesis to be all messed up. So normal stuff that we should see, hematopoiesis, does not occur anymore. So with acute leukemia, usually the person's tired, they're worn out, they ache, they're pale, they're anemic, but it's normochromic, normocytic anemia. The platelet counts are low, so we get thrombocytopenia, and the side effect of that is they have gingival bleeding. They're bleeding through their gums, epistaxis, nosebleed, ecchymosis, bruising, and petechiae, little red dots that you'll see on them. Sometimes they'll have a fever, and that can be due to the leukemic process that's going on, or there's an infection. And the white counts can do everything. They can be like nothing to extremely high. I've seen as high as 2 million and as low as can't find them. So what will happen also is they have hepatosplenomegaly and lymphadenopathy, and sometimes bone pain. So what we're saying is the liver and spleen are enlarged and the lymph glands are enlarged. So that depends on what type of leukemia that we're talking about too. So there's different ways we classify anemias, acute leukemias, basically all leukemias. But the first one was FAB, which is called the French American British, and that was developed in the 70s. And that basically goes on just differential results, scatter plots. In other words, you're looking at the morphology. So it's very limited. That's all we had. That's basically what we do in the lab until we start getting genetic and molecular chromosomal issues, CD markers, immunophenotyping to get us a better way to identify. So basically, we could say it's a myeloblast or a lymphoblast. I mean, and you went by the company it keeps. And basically, what I'm saying is that if I saw like bands and sags, a few of those, then there's blasts, it was probably a myeloblast. If I saw lymphs and then there's blasts, it was probably lymphoblast. So you go by what they call company, that they keep. So then in 2000s, the World Health Organization, WHO, and you can see it's constantly updated. This is where we start getting in the molecular, the chromosomal genetic issues that we're seeing, and immunophenotyping with flow cytometry. So all that's put together, which gives us a more accurate diagnosis, better treatment plan, and a better prognosis. So with both, they have to have at least 20% blasts in their bone marrow. So the first one we'll talk about is acute lymphoblastic leukemia. This is usually, statistically saying, usually seen in children and adolescents. It peaks at 2 to 5 years. If it's seen in adults, that's not a good thing. The prognosis is very poor. So when you look at acute lymphoblastic leukemia, we can break them down into either B cells or T cells. And you really can't tell morphologically what these cells look like. That's why the immunophenotyping is crucial to determine that, because there's totally two types of treatment that's involved in this. Now with the B cell ALL, they're tired, they run a fever, they have bleeding, because the white counts are messed up and they're not working, and the platelets are really low usually. Lymphadenopathy, splenomegaly, hepatomegaly, and one of the hallmark features that we see is bone pain. The kids complain of bone pain. Now, what also can happen, if it gets pretty advanced, it can get into the central nervous system, where the malignant cells will cross a blood-brain barrier and get into the brain, and then we'll see it in the spinal cord. That's definitely not a good sign. The other one is T cell. And this is usually because of the thymus going crazy, which is a mediastinal area in the chest. In other words, it's like upper part of the breastbone, sternum right behind it. And the thymus is just going crazy because that's where the lymphocytes differentiate into T cells. So again, with this, they still have the anemia, thrombocytopenia, organs are still enlarged, and they still have bone pain. That's why it's so important with flow cytometry to determine, is it T cells or is it B cells. So if you look in your book, you'll see a huge list. Table 31-2 will give you the WHO classification, and we're just going to pick on certain ones that we see in the peripheral blood, the most common ones. So the B type, lymphoblastic leukemia, lymphoma. Remember, lymphoma is basically just isolated in the lymphatic system. Usually more of a solid tumor, lymph nodes. It hasn't spilled or hasn't gotten into the bloodstream yet. Once it's in the bloodstream, then it's called leukemia. You can have either or both. So there's 9 different types associated at this time until they make another classification. But looking at chromosomal cytogenic abnormalities. T lymphoblastic leukemia lymphoma really doesn't have certain kinds of biological. I mean, they'll have different features that we'll see in the bloodstream and on their skin, but they really don't have a lot of specific biological markers that we know of. So when you're looking at lymphoblasts, which I'll show you a picture in a second, there's small lymphoblasts and there's larger lymphoblasts. So let's look at the picture here. So you see on the left, these are the small lymphoblasts. They're a little bit bigger than a red cell. You can hardly see any kind of cytoplasm to it. Usually there's only one nucleoli that you can see in there, which I'm pointing one. I don't know if you can see that or not, but they're smaller. than the larger ones. The ones on the right, you can see that they're larger. We've got like more of a fluffy type of chromatin that we'll see. Definitely more cytoplasms, can still see nucleoli, but you can see how much bigger they are. The small ones have a very dense chromatin, while the large lymphoblasts have a more spread out, fluffy kind of chromatin involved, more like a three-dimensional look to it. So when we look at FAB classification, because this is what we'll be doing in the lab, because we don't have all the other stuff, all we have is morphology at this particular time. Its FAB classification is called L1, L2, L3. L1 is usually seen in children. It's the small type of lymphoblast that we were looking at. And L2 is usually adult. That's a larger lymphoblast. And pleomorphic, meaning the morphology is really weird. It's got a lot of different things that we saw with the larger ones. And then L3, Burkitt's. Right now it has, a much better prognosis. It's still considered poor, but if it's treated quick, it has a very good prognosis. But it has its own unique type of morphology, which I'll show you a picture in a second. It's very deeply basophilic cytoplasm and has a lot of vacuoles in it. So here's the pictures of L1, top left. You can see very small lymphoblasts. They usually come in groups. L2 is the more pleomorphic, the larger lymphoblasts that we're looking at. And then L3, you can see where there's vacuoles in there, very dark blue cytoplasm, and that's the Burkitt's, or L3. So when you start throwing in the WHO classification, then we start looking at flow cytometry. And flow cytometry gives us those CD markers, this cluster differentiation markers. And that gives us the phenotype by immunological methods, as we talked about when we talked about the flow cytometry chapter. So if we break those into subtypes, we have the early, which is called the pro or pre B cell type ALL, the intermediate, which is the most common of the BALLs, and then pre-B ALL, different than the pre-pre. I know it sounds odd, but that's just the way they have it. And then the T cell ALL. So you can see the immunophenotyping. They do have some commonalities with them, like the B cells all have CD34, which is a very early, like a type of stem cell kind of stuff. And the B cells usually have the double-digit CD markers, like 19, 10, 20, 22 is usually what we'll see. And they have what's called a TDT, which is a type of stain that's used. TDT is used to tell that it's just lymphocytes. So that's why you see it in the T cell ALL. Now the CD markers that we see with the T cell ALL are usually single digit. 2, 3, 4, 5, 7, and 8. It's usually what we'll see with those. And we'll explain a lot more about those when we get to immunology too. But with the B cells, we have what's called a CD22, which is actually seen on the cytoplasm. It's in there as opposed to being on the membrane antigen. Now here's some molecular things that we see, and we'll go into those a little bit as to what each of them are. The genetic for TALL is a Notch1 type of molecular finding. Again, when they make these diagnoses, it's a combination of the morphology, all the patient's clinical features, physical assessment, molecular findings, cytogenic, immunophenotyping. All this is done. That's why it's such an accurate type of diagnosis. The B lymphoblastic, you can see there's translocations, which is a BCR-ABL, the translocation of 922. Translocation, which is variable, which is seen in mantle cell type of lymphoma. Translocation 1221, and you can see the Renux 1, hyperdiploidy, and hypodiploidy. So it depends on what you're seeing. So usually with ALL, it's pretty amazing, but the prognosis is really good if it's caught pretty soon. That's the key to it all. Adults is not quite as good, but it's getting better all the time. So again, it depends on how many blasts are seen, what the immunophenotyping, the CD markers that we're talking about, the genetic abnormalities, the chromosome abnormalities that we'll see, and then is the spleen or liver enlarged or the lymph nodes enlarged. All that is necessary before we can make a prognosis. Now, acute myeloid leukemia is more common in adults as opposed to children. Children is usually acute lymphoid. But the chances of getting AML, acute myeloid leukemia, increase as you get older. The physical presentations with most leukemias, tired, pale, bruising, bleeding, fever, what we were talking about. This stuff called DIC, which is disseminated intravascular coagulation, which will explain this a lot more as time goes on. For some reason, they start clotting within their body for unexplained reasons, which can be fatal if it's not caught quick enough. Other things that we'll see is these malignant cells start invading other areas of the body as opposed to just the bloodstream. Spleen's enlarged, and one of the big side effects of this is what's called tumor lysis syndrome. Basically, what it means is once they start getting chemotherapy and they start killing all these cancer cells, you have to be so careful because inside the cancer cells, remember, is DNA, and one of the parts of DNA is the purines and pyrimidines, the base pairs. So the purines, when they break those down, have uric acid in them. And what will happen is they kill too many cells too fast, that uric acid will actually get into the kidneys and destroy the nephrons, which will cause them to have renal failure, kidney failure. So that's why they have to monitor the uric acid and the BUN and creatinine on patients that are getting chemotherapy, that we can't give too much, but we got to give enough. And usually when we give people chemotherapy, we give this stuff called allantoin, which helps break down the uric acid a little bit more. So, we know it's coming, so we try to watch out for it. So, but that is a big thing that we have to constantly monitor. That's why it's so important. Blood work on patients getting chemo is monitored very frequently to make sure that we can check for side effects quickly and change the therapy if necessary. So how do you make this diagnosis? Well, a CBC would be a great start. Usually the white count, you can see it can be from little to nothing to everything. So anything's possible. So the white count won't always be, it could be normal. I've seen that too. They're usually anemic. It's a normochromic normocytic anemia. They usually have a very low platelet count. Not always, but usually. And the peripheral smear, we start seeing blasts. And we go by the company they keep. Myeloblasts are usually there because we'll see some bands and segs and stuff like that. So then they'll recommend that a bone marrow be done. So if the bone marrow is done, then that will determine if we have greater than 20% blasts, and usually the bone marrow is hypercellular. So that makes it easier. Then we can do flow cytometry to do immunophenotyping. Then they'll do cytogenetics to see what genetic abnormality. And that will take a few days. That's why the FAB classification comes in first, because we have a smear and we can identify, start treatment, start things on the roll. You don't want to wait. So some of the side effects of having AML is hyperkalemia. In other words, potassium will be high. Hyperphosphatemia, phosphorus will be elevated. Of course, what we just talked about, hyperuricemia, the uric acid is elevated. And then we'll have hyperuria, in other words, uric acid's increased in the urine. And the calcium, hypocalcemia, calcium starts dropping. So that's just the side effects, which has got to be monitored a lot. So the World Health Organization, WHO classifications, we need to do the CBC, and usually when you look for the blast, you look to see, are they large blasts? What is the NC ratio? Do they have nucleoli? Which you can see, this is a blast here that's got nucleoli in it. It's got a couple of them in there. The chromatin is, they call loose. It's not really packed tight. There's a moderate amount of cytoplasm, and you can see these little red, like rods inside of the cytoplasm, and they're called our rods. Our rods are actually primary granule fused into a rod shape, and that's usually diagnostic of AML. So if you see those, we can start treatment. I mean, we don't have to wait. We sort of know what kind of angle we got to go to. So the bone marrow will definitely give us the definite diagnosis of greater than 20% blast in the bone marrow. And then we start looking at the different categories of AML, depending on the immunophenotyping, the genetic abnormalities, and molecular stuff that we can find. So this is a WHO, and we're going to be covering both because you need to know both. The AML, these are the ones that we see with genetic abnormalities. You don't have to know the whole spiel of it, but you have to be able to recognize it. Like AML with translocation 821, that's probably a good 10% of the cases that we see. AML with inversion 16, AML with PML, which is promyelocytic leukemia with RA, which I'll explain later. AML with translocation 911, AML with translocation of 69, AML with inversion 3, and then AML with a mutated NPM1. I know it's a lot of stuff, but like I said, the better diagnosis, the better the treatment, the better the prognosis sometimes. So here's the first one that we talked about. This is AML with translocation 821 with the ReNux-1 molecular problem here. Like I said, that's about 10% of the cases, and you can see the blaster. They're pretty large. I mean, look at a normal lymph. You can see in that top one there with the blast around it, and you can see the red cells there. So the blasts are pretty big. They have some eosinophilic, some granulation in it, not much, but there's allo rods in there too, and you can see the nucleoli present in there. And this is similar to the FAB classification M2, which we'll talk about here in a little bit. Now, usually what we'll see in these patients is the granulocytes look like Pelger-Hewitt. I mean, it isn't Pelger-Hewitt, but they call it a fake pseudo Pelger-Hewitt. In other words, they're hypo-segmented. The CD markers that we see with those, CD19, 56, 13, and 34 with the HLA-DR positive. Usually this is seen in younger adults, and it works, have excellent treatment with chemotherapy for this. AML with inversion 16, this is blast, and they have what's called a myelomonocytic look to them. In other words, they have a myelocytic type of cytoplasm with a monocytic type of nucleus, where it's more like a monocyte. This is comparable to what's called the FAB classification M4. So what we see with this particular classification is dysplastic eosinophils. So you can see the CD markers that come with this also. Again, responds well to chemotherapy. Okay, AML with PML, which is promyelocytic leukemia, with RA. RA is a retinoic acid receptor, which we'll explain in a little bit more here later in the chapter, is a translocation of the 1517. These are usually seen in their teen years up to the age 60 years of age. They are promyelocytes with just usually a lot of primary granules in it. But you can see how the promyelocytes, in the bottom picture, they don't have as much. They call them the agranular type of PML. But they are like bilobe. They got like kidney shape. They're really weird looking. So the cytoplasm in those, is pretty agranular, where the ones on top have a lot of granular. The most common one is the one at the top, the granular one. So their CD markers are 13, 33, and 15, but that's usually not too strong. And it responds to what's called ATRA treatment, which is arsenic trioxide retinoic acid treatment. Responds really well. Okay, AML with translocation 911. Reason I don't say the rest is that that translocation really pinpoints it really well. But this one is sort of common in children. It's comparable to the FAB M4, M5, which again we'll explain later. You can see the CD markers that come with it, CD4, 14, 64, and what's called 11B. But in this particular one, it's a monoblastic. In other words, they're either monoblasts or promonocytes is usually what we'll see. And usually when you get into the monoblastic, we start seeing extramedullary. In other words, stuff outside of the bone marrow. And usually what you'll see is the gums are like really puffy and granular, like granulomas kind of look, skin kind of stuff going on. So that's how we usually find it. It doesn't have, right now, it doesn't have a very good prognosis. And again, they go into that DIC, that clotting mechanism they have with it. Okay, AML with translocation 6-9. This is more of a basophilic kind of look, and you can see some of those basophils in there. Remember, the basophils, those granules have heparin and histamine, and they are water soluble, so you have to be careful with the staining that it doesn't wash it off. Usually that's seen usually in younger children and does not have a very good prognosis at this time. Okay, AML with inversion 3. This is usually seen after somebody's had myelodysplastic syndrome. That's the MDS, which is a chapter later on in this semester. But these cells are usually megakaryocytes. They're just abnormal, small, dysplastic, they call it. Hypolobulated, because normally megakaryocyte has 3 to 5 nucleuses inside of it. But you can see here that big fluffy one. It's like left of center. Very unusual. Hard to, I mean, it's just, my God. And then the cell, like to the right side of center, you can see how the cytoplasm has got like stuff sticking off of it. That is characteristic of megakaryocytic lineage. So this follows like FAB, M0, M1, and M7. Again, when I get into those, you'll understand a little bit what I'm talking about. So we also have acute myeloid leukemia with abnormal myelodysplastic related changes. In other words, it's just making the definition of AML, and it has the abnormality of some of this other stuff, but we really can't pinpoint what it is yet, because it might take a little longer for identification. There are myeloid neoplasms that we see because people are on chemotherapy. It is a side effect of chemotherapy of other kinds of cancers that people can get this. And usually one of the common ones we'll see, which is more of a chronic type of myeloid leukemia. But that can happen. That's a side effect of any kind of chemotherapy. That's why it's so important people are constantly checked all the time to make sure that we're not having that problem. That issue is arising. So, to the FAB classifications, okay? The FAB classifications start with an M, like the acute lymphoid started with an L, so now they start with an M. So there's M0, M1, M2, M3, M4, M4EO, M5A, M5B, M6, and M7. All right? So it's important you know these, because this is how we identify until we can get all the other lab work back. The immunophenotyping, flow cytometry, genetics, molecular, all that stuff back. So M0 is AML with what's called minimal differentiation, and we'll see pictures here in a second as to what they all are. AML without maturation, AML with maturation, promyelocytic, myelomonocytic, myelomonocytic with eosinophils, monocytic, poorly differentiated, monocytic, well-differentiated, erythroid leukemia, and megakaryocytic. Okay, because remember, myeloid means it's coming from the bone marrow. That's why we're talking about red cells and platelets. So, just so you got it, we're going to be talking about some cytochemical staining that comes with it. They're not done as much as they used to be done, but again, it can be done. So, one of the most important cytochemical stains that's done is called myeloperoxidase. Also, in D2L, you will see a flow chart for cytochemical staining to help you break this down to determine which acute leukemia it is. So refer to that also. So myeloperoxidase, remember, is the enzyme that is part of the primary granules of granulocytes, usually. Lymphocytes, extremely rare. So you can see pictures here of positive myeloperoxidase. Now, the staining, you see the granules or the enzymes being seen. Now, the color depends on what test method you're using, but this one's using where the brown is showing myeloperoxidase. Another stain that's done is Sudan Black B, and you can see the initials there because that's how they'll have those sometimes. They'll just show the initials and say positive or negative. But this will stain the lipids inside of the cell itself. It's similar to the myeloperoxidase. Granulocytes are usually positive also. So those two stains, the myeloperoxidase and Sudan Black B, will show its myelocytic origin. Esterases are usually to differentiate myeloblasts from usually monocytes. And the reason we do that is because if, say, the cell is negative or positive rather for myeloperoxidase, Sudan Black B, we know it's either myeloid or monocytic. So the esterases will determine that. So we can do the non-specific esterase, which is usually positive for the myelocytic series, and then the specific naphthyl ASD chloroacetate is usually positive for the monocytic. That's what we'll see. And you can see the colors, like the orange at the top and like the dark red, I guess you can see for the bottom. All right, now, getting back to the FAB classifications. Usually M0, remember this is FAB, M0 shows minimal differentiation. In other words, what they're saying is the cell really it's committed, but we really can't tell that it's myeloid yet. Just know it's not lymphoid. That's about it. It's not really getting special characteristics, the differentiation, making it really present itself as myeloid now. So you can see the CD markers that come with that, 13, 33, and 117. So we don't really see the good granulation that we should be seeing. We don't see how the cell's maturing. And this one is so not completely myeloid yet that the myeloperoxidase and Sudan Black B don't even come up positive now. So of the AMLs, 5% of them are M0. M1 is AML without maturations. In other words, what we're saying is 90% on that smear is going to be blast. I mean, you can see it's like sheets of it, like it's just the same cell that does. I mean, you don't see the bands, the sags, the metas, the myelos. 90% of what you're looking at is all blast. And you can see the same markers. That's why the CD markers are telling us usually if it's myeloid or lymphoid. When we get into the chapter about mature lymphoid neoplasms, that's where the CD markers really stand out, really help us a lot. So even M1, only 3% of them will be positive for the Sudan Black B and the myeloperoxidase at that time. So now M2 has maturation to it. So we still have the 20% blast, but now about 10% of the cells are starting to mature. So you can see that there's some sags and bands and metas, myelos, all that kind of stuff, in addition to the blasts that are in there. But again, remember, these are not normal cells. These are leukemic cells, so they don't look like normal stuff that you normally see. And when patients get chemotherapy, they really start changing big time. So it makes it very difficult. That's why it's crucial that you have your morphology down so you can identify the cell as to what it is. So you look at all the characteristics of the cell and try to identify it to the best of your ability. And again, you have the supervisor or the pathologist to confirm whatever you see. That's why there's always atlases. Everything's there to help you. If you do not know what it is, then do not, release the result out for the physician. Get a secondary review. So here you can see there's some allo rods present in here. The myeloperoxidase is positive. Again, the same CD markers that we were talking about, 34, 13, 33, and 117, are seen with M2. Now, M3 is promyelocytic leukemia, so you can see promyelocytes. Remember all those primary granules in there? They still have a blasty kind of look to them also. Usually when we see like tons of allorods, which you can sort of see right up center, a ton of allorods, and they call them Fagot cells. Usually they have the retinic acid receptor antigen that's positive. They call it RARA. Believe it or not, the treatment for this is fantastic. If it's caught early enough, you can have almost 100% remission. Amazing. But one of the bad side effects of promyelocytic is DIC. In other words, a clot. So if it's not caught early, the patient's not going to live. Very crucial to pick up. M4 is myelomonocytic. Again, it has a myeloid monocytic kind of look to it. So it's more monocytoid nucleus, more myelocytic kind of cytoplasm. So usually the monoblasts are pretty large, got a lot of cytoplasm. They got what's called pseudopodia. In other words, it's got little fake pseudopods sticking off, little blips in the cytoplasm sticking off. You got a little bit of granulation, multiple nucleoli present, but the monocytoid kind of look to that nucleus. Again, the CD markers are there, 1333, but now we're seeing the monocytic antigens popping up, which is 14, 4, 11B, and 64. And it's myeloperoxidase positive also. M5 is monocytic leukemia. So in this one, you can see the two different here. This is the monoblastic at the top and the monocytic at the bottom there. So, of course, to be an acute leukemia, they have to have greater than 20% blast present. And because they're monocytic origin, they have CD14, 4, 11B, and 64. So the blasts are large. They really don't have granules now. Big nucleoli, very monocytoid, cerebriform looking nucleus. Like I said, there can be, like we talked about, the variant. There was an M5A and M5B. The B is more where they're promonocytes and really not blast present. Again, with monocytic leukemia, there's extramedullary involvement. In other words, it's outside of the bone marrow now. So now we're getting skin, gum infiltration, and platelet count is low, so they have bleeding disorders because of it. M6 is an erythroid leukemia. We can have just pure erythroid. You can see all the nucleated red cells present in there. They can actually be bi and tri-nucleated, so it's insane. There is greater than 80% of the cells we're looking at are erythroid, so we really don't see any kind of myeloid side of it. So the cells are very abnormal, so they're very dysplastic. You will see Hal Jolly bodies present in the red cell morphology. Just remember, Hal Jolly bodies are part of the nucleus. Usually the spleen can take it out, so right now it's so abnormal the spleen can't handle it. And if we did a stain, we would see ring sideroblasts. In other words, with ring sideroblast, usually it's done in the bone marrow, but when you have this type of leukemia, it can be done in the peripheral blood. So it's that Prussian blue stain that will stain the iron around the nucleus of a red cell, hence a ringed sideroblast. M7 is acute megakaryoblastic leukemia. Again, a cytopenia kind of deal, but the platelet count will be usually higher. We have greater than 20% megakaryoblast. It's seen in patients with Down syndromes, and there is an adult variant with this. But if you look at the picture on the left-hand side, they have what's called cytoplasmic blubbing. See that like stuff sticking off the nucleus? That's what I'm talking about. That's characteristic for megakaryocytic looking abnormalities. So its CD markers are 41, 42, and 61. The stain, if you look on the right, that's a bone marrow aspirate, and it's a special immunostain that's done to look for the platelet receptor. And you can see with that brown, there's a lot of platelet stuff going on. These megakaryoblast kind of stuff present. Treatment for the erythroid megakaryoblast usually doesn't work out that well, but like with any of them, leukemias, if caught early, makes a difference. And then there's acute basophilic leukemia, extremely rare. This is showing a patient here that has remember the basophils are, they can be pretty big, but remember they're water soluble, so you have to be very careful looking at these cells. CD 13, 33, and 117 again. And then there's acute myeloid leukemia, what they call it sarcoma. In other words, it's extramedullary, so blasts are seen out in the tissues now, especially the skin and the GI tract. That's usually the biggest thing that we'll see. But it can be seen in the lymph nodes, so it's rare. Then there's myeloid proliferations that related to Down syndrome, like we were talking about monocytoid also. But that can also happen because there's a very similar chromosome abnormality that occurs. And then we have what's called the catch-all. The acute leukemias of ambiguous lineage. In other words, we have no idea where it's coming from. It doesn't really have the markers it needs, the flow cytometry. Nothing goes to where it wants. It doesn't really pinpoint. And then there's one that's called mixed. In other words, it's the myeloid and the lymphoid together. So you try to make a diagnosis on the immunophenotyping, the CD markers. So it's very hard to treat. It all depends. With all these patients, treatment, and diagnosis and prognosis all depends on finding it quickly, identifying it correctly, and monitoring constantly. It's not just make the diagnosis and treat. You have to monitor constantly because it can change throughout. So, to review for this chapter, what are the two different types of acute leukemias? Prognosis for them, like ALL is usually childhood, adults, very poor prognosis. The phenotypings that we see for the ALLs, what's the difference between an ALL and AMLs? What's the clinical presentation? Make sure you know the FAB classifications, and then the individual translocations. We only picked, I think, 5 or 6, so we tried to pick the top ones. Again, we'll go through this in class. Make sure you read the chapter and the questions in the book. I didn't cover every single thing in the book because the test won't include every single thing in the book, but what we were talking about in class. If you have any questions, please let me know. Thanks.